Thanks, Dave. Good to see you. I realize I'm the only thing between you and the afternoon cup of coffee, so we'll try to, for this, sit back, relax. I have the benefit of practicing in a large CLL practice. We have about 3,500 clinic visits per year, 200 to 300 new patients per year. So I'm more of I'm a clinical guy, and so I just want to share with you kind of what we're seeing in the clinic, both in patients we see, the ones we're getting called by our referring physicians, and it's an exciting time. So let's see here. What do I point this at?
It should work. Maybe gotta lift it up a little.
There. My disclosure slide. Okay. So one of the biggest thing that I think that's happening in CLL is that with everything you've heard already from our early discussants, is that we are, the CLL is changing, and that you're seeing more, you're going to end up seeing more and more CLL patients because the prevalence is increasing. Due to the use of these new agents, more and more people are living longer and longer, which is exactly what we want. But it does change the natural history of disease. This disease. We've seen this with multiple cancers, that as we have gotten more successful in treating, we see new natural history. Just a couple quick slides. CLL, if you look at the classic RI classification from, again, 1975 versus an update from our Mayo cohorts, we're seeing that in the early stage, there's not that much change, but especially if you look at stage 3 and 4, the patients who obviously have needed treatment, there's a significant improvement in survival. This is data from SEER showing the relative 5-year survival of CLL from the 1970s to 2010, showing a significant improvement in the 5-year survival. Now again, both slides I've shown you are pretty much before we have really been into the realm of targeted therapy. So these hopefully will continue to improve. The timeline of CLL drug development is shown here, going back to the 50s with clorimazole and prednisone, and then down really through, it was bendamustine now about 10 years ago, that started a whole new onslaught of new agents, Benda, OFA, Hobina, Ibrutin, Idela, venetoclax. So we've seen a lot of new agents just within these last 5 to 10 years. This slide has already been shown to you, and it's Susan O'Brien's updated ASH of the original cohort of refractory relapsed CLL patients. I'd like you to just look at the arrow I put in the bottom, showing it's kind of like at the mall, you are here. This was approved now February of 2014, so we're 3 years, 2 months. So in your practice, those patients that you started 3 years ago are the ones that will start, as you look at the fall off of progression-free survival, you will start seeing more patients progressing, more patients where you need to move on to other therapies. So these projected, as we start seeing more and more CLLs living longer and longer, we will have more monitoring. We'll have to learn how to monitor for complications of these new agents. At this point, it's uncertain if targeted therapy will alter the rate of complications such as autoimmune cytopenias, Richter's, infection risks, secondary malignancy. Regarding the debate you just heard, if early intervention could impact those 4 things, that would be a strong argument for early intervention. And as we look at these early intervention trials like the CLL-8, it'll be interesting to see what the risk of the immune side effects are. The costs are becoming more of a problem. Many of our patients, as was mentioned earlier, you do need to follow almost exactly the wording of the FDA labeling. Co-pays generally are okay, but things like the Patient Access Network, as many of you probably know, helps fund co-pays, pretty much dried up towards the end of last year, and I think there is some money again now, but it's not as easy to get co-pay assistance as it was, say, a year and a half ago. So one of the areas that CLL classically through the years, there have been numerous complications, many infectious, many due to the immune defects and having CLL, many due to treatment-associated complications such as neutropenia and decreased CD4, and then the non-infectious. So one of the questions is new targeted therapy going to affect that or not? And I think it's important that we don't blame new targeted therapy for some of these complications that go along just with the disease itself. Here's an example. This is a patient of mine who I'd followed for 7 years. He had 11Q-. He had complications of autoimmune hemolytic anemia, ITP, autoimmune neutropenia. I had treated him multiple times. Last August, he came with that look of ashenness, sweating, feeling poor. His spleen had markedly increased in size on exam. And on workup, he did not have signs of Richter's transformation, but instead had clonal evolution to acquire 17p. If you look on these two, these were done at the time of progression to 17p. December, and he responded. In December of this year, he was found to have a small squamous cell carcinoma inside his inner conch on the left ear. He was seen by a Mohs surgeon in Sioux Falls who called me and said, I think I feel nodes in his neck. We brought him over, did our ENT did an FNA. It was metastatic squamous cell carcinoma with also multiple bony mets, and he passed away about 2 months ago. And if you can compare, this is how virulent skin cancer even can be in some patients, where this PET was done in August when we were looking at his 17p progression. This PET is in January, and you can see also on this, and you can also see some of the bony lesions. So it's always important. I have all my patients use sunblock, try to prevent. Most of our patients, we like to have them see a dermatologist once a year. Not that it would have changed this person's outcome, but it gives you an idea. Skin cancer is more aggressive and more likely to recur. As we've moved from the traditional chemotherapy into these agents, we have new therapies. I'm double-boarded in oncology and hematology. For many years, I did outreach in a couple of our smaller cancer centers, so I was treating GI malignancies and became comfortable with all of the as some of the newer agents that started having skin rash and the different things. And now we're starting, we've traded some of the nausea, vomiting, and neutropenias for rash, diarrhea, fatigue, etc. Just some practical considerations. I put several of these slides in. I won't read through them, but they're in your slides. But just one thing with ibrutinib, I strongly recommend that either you have a very good chart or have a very good pharmacist that you work with, because there are significant interactions with the CYP3A4 meds, and I'll show you, there's a slide coming up. The bleeding risk has been alluded to already. It's about 3% major. We try to avoid or minimize other anticoagulation, especially warfarin. They should not take nonsteroidals or fish oil or vitamin E. And we should, the company insert says stop at 3 to 7 days pre and post surgery. There's about a 10% risk of atrial fibrillation, 15 to 20% risk of hypertension. Some are recommending, and it's reasonable to screen for hepatitis B. We have now seen a number of shingles reactivations and disseminated zoster in our patients on ibrutinib. And so we are, in our group, have gone to prophylaxing them with acyclovir 400 BID or valacyclovir. There was an article in Blood from Adrian Wiesner showing several cases of PJP. Most of these patients, I think you should at least consider this, especially if there's a low CD4 count. This is just a list for you, not just as reference, it's in your slides, of some of the major drugs that go through the CYP3A4 pathway that will require you to alter your dose of ibrutinib. We did a study and presented it at ASH a year and a half ago, and this is looking at the first 99 to 100 patients that we put on ibrutinib in our group from November of 13 to July of 2015. And the bottom line's on the far right. 63% of patients who we put on ibrutinib in that first period of time had the potential for interaction, either drug-drug interaction or anticoagulation, et cetera. And about 4% were on medicines that could potentially decrease the effective dose of ibrutinib. So that's where being in contact with your pharmacist or checking is appropriate. This is for your reference. It basically is just from Samir Parikh from my group and Heidi Fennis, that if you have an inhibitor, then if you need ibrutinib, you have an inhibitor. If you can change the drug, change it. If you can't, decrease the dose. And we do not increase the dose on inducers. And so that's for your reference. Idelalisib, similarly, pointing out that there are drug-drug interactions, hepatic toxicity, colitis, both an early colitis and a later, more significant inflammatory colitis that can be associated with bowel perforation. For the later one, for the early one, many times drug changes will help. For later ones, oral budesonide or steroids, and this can be quite serious, and the risk of pneumonitis. My last slide, and this is for reference, it lists a very good article of which Dr. Furman is one of the authors on management of idelalisib toxicities. I took this from the idelalisib prescribing information. With these new targeted informations, and again, this is not a commercial bias, but you often, if you aren't sure, there are some very good resources right in the company's prescribing information. And this goes over dose modifications in idelalisib as recommended by the company. And it's actually a good, quick reference you can get to. So the venetoclax has been mentioned. This is just a brief one slide of a Jeff Jones presentation regarding venetoclax and ibrutinib idelalisib refractory, showing a very good response rate. The main side effects were neutropenia, and also in venetoclax studies in general has been the issue of tumor lysis. And in the early studies, there have been several deaths with tumor lysis. We are starting to use venetoclax more and more. Most of us are expecting venetoclax to get expanded FDA approval, perhaps with combination with rituximab for treatment of relapse. And so as we're getting more experience with this, as we have people failing ibrutinib, what is being used, and this is, again, well documented in the package inserts, is a ramp-up dosing. And the main thing we're watching for is the risk of tumor lysis. So you start with a first week of 20 milligrams, second week daily, then 50 daily, 100, 200, and then go to this is your target dose. Most people, you can get up to that. There is some neutropenia. The main thing is, if there's a significant tumor burden on day 1 of week 1 and day 1 of week 2, they should be admitted, hydrated, and monitored for tumor lysis syndrome. This is just, again, if you use this drug, there are drug-drug interactions, which I'll come to in the next slide, but how they market it is actually, and I had to learn this the hard way, there's a 1-month starting pack. So that starts with that has, in a bubble pack, it has all the drugs they need for the first month, and then subsequent to that, you have to do a second prescription for the medication using 100 milligram tablets. We will have this approved and then have them bring it to the hospital because our hospital pharmacy, especially for Medicare, would not be wanting to give that as an inpatient. And then there are guidelines that we have worked into our chemotherapy programs, but are also published and in the recommendations regarding the risk of tumor lysis and how much tumor lysis prophylaxis needs to be done. And these, again, are actually good references. In addition, venetoclax can also be metabolized, and so these strong CYP3A4 inhibitors do require some dose changes. And then, not being a pharmacologist, there also are what these called P-glycoprotein inhibitors in drugs, so like erythro, cipro, diltiazem, fluconazole for the CYP, but then the P-glycoprotein, amiodarone, azithromycin, where these affects drug transportation across the membrane and the uptake and efflux, and so that if you inhibit that, you may also need to change your dose of venetoclax. And so these are just, you need the same concerns as ibrutinib plus these pico-glycoproteins. So over the next few minutes, I want to go through some cases. Change is coming. No one is making you do anything you don't want. I'm just saying we're all headed for Dodge City, and we think you should come along. So this is a case, and all these cases come from our case series. 69-year-old, previously untreated, had 17P. He progressed to need therapy. In late 2015, we wanted to do therapy for him. He could get a better, obviously much better copay, or actually no copay, getting it through one of the regional VAs. He went there, started it. 2 months later, I was called by both him and his physician as they had stopped the ibrutinib because he was failing it, although his nodes had receded. As a reminder, with ibrutinib, your white count goes up before it goes down. So you'll see an increase in your lymphocyte count, and this may take 6 to 18 months to come down. This is fairly typical. Sometimes it takes longer, but generally they all do come down. We tend to not have problems with the high levels. And this is not a flare, it's just a redistribution. A second case, a 72-year-old with relapsed CLL, recurrent head and neck squamous cancer, is on has oral candidiasis and is on fluconazole, which is a CYP3A4 inhibitor. He is started on ibrutinib full dose and had a good response. Counts were normalized. Because of his squamous cell, they wanted to needle a lesion in his lung. They did not. So his dose should have been dropped to 140 based on guidelines. They did not drop the dose and they did not stop it, and he had a significant hemopneumothorax from bleeding. The bleeding risks, grade 3 and higher, are more in the range of 3 to 5%. Bruising is very common. Some of our patients who have falls or have trauma have a lot of bruising. The guidelines are 3 to 7 days. For anything major, I would go 7. We have had significant post-op hematomas for excisional lymph nodes with just holding for 3 days. So I tend to, for an easy biopsy, 3, anything else 5 to 7. And I'm just going to go past that because Dr. Furman gave some information. Kind of one of the things that's becoming harder and harder for us to be, I think, definitive on is the management of Afib. Afib, again, CLL happens in older individuals. Afib happens in older individuals. And so there's a basal amount of Afib that's going to occur, plus we know the drug induces it. Generally, when it happens, we'll suspend the drug, start appropriate antiarrhythmia therapy, and then consider reintroduction with generally 1 dose level reduction. Occasionally, and sometimes that's beneficial, sometimes it doesn't matter what the dose we go down to, it keeps happening, and so that we will look at switching. We try to avoid warfarin or low molecular weight heparin, and the direct-acting anticoagulants are what we've used if their CHADS-VAS score is high enough. This is a businessman who had CLL. He was started on ibrutinib. He had mild hypertension. He was what we call a Minnesota snowbird, and he was in Florida. His blood pressure started going up. First they added diltiazem, full dose, then metoprolol. He finally came back up north, and he's seen in Illinois, and then actually came up to see me. He sees me about once or twice a year, and his blood pressure was still high. The answer here was his ibrutinib dose should have been dropped with the addition of diltiazem. And so what we just did continued diltiazem and hydrochlorothiazide could stop his metoprolol, and he did fine. One of the things we're starting to see is compliance. This is a physician patient of mine who has been on ibrutinib now for about 2 years. During an evaluation, he said, I've got some mild joint aches, myalgias, and they're more grade 1, and I just said, just stick with it. Often these myalgias happen a year or so out. 2 months later, we get a call for a renewed prescription from his insurance disease manager, and they go, We just need 280 a day. And they go, no, he's on 420 a day. No, he's on 280 a day. He had self-reduced. And so actually, after that case, I've been more careful checking with patients, and in fact, sometimes they will self-reduce, and so it's important regarding that. Arthralgias can occur, and I'm just going to pass through this one. A couple last slides. Following stopping ibrutinib in relapsed CLL, there's plenty of studies showing that survival is low. It's more so in patients who are progressing. If you need to stop it because a person's on a vent for a month or has a major abdominal surgery and can't eat for a while, often you can get by for 3 to 6 weeks watching. But if they're progressing, it's worse. And this is the final case. This is a patient of mine who was 60 years old, had multiple prior therapies. He's on ibrutinib. He has 17P. He's up in the Twin Cities, is hospitalized with a pneumonia. They held ibrutinib while he was in the hospital because they were worried. He also has chronic neutropenia, which is not related to ibrutinib. He came back and saw me 5 days post. So he's about 11 days post stopping ibrutinib, and his nodes some of them had tripled in size. His PET was avid. I was worried about a transformation. I biopsied, and it was just CLL with prominent proliferation centers. We restarted the ibrutinib. So some patients, you start ibrutinib, and you don't see much for 3 to 6 weeks or 2 months. Some people, you stop the ibrutinib, and it changes rapidly. Now I'm calling this a Tempest in a teapot sign. When you see this, if you stop ibrutinib and you have a very rapid flare, especially in a patient who's been on for a long time, start getting worried that they're becoming resistant. In this gentleman, we did the mutation testing. It's a long turnaround time. It came back 4 weeks later. He's on ibrutinib now. It was positive for the cysteine 481 mutation. So now we know he is resistant by mutation, but within a week or so, his nodes were rapidly growing on ibrutinib, and so we switched him to Idela and then eventually to venetoclax. So in this group that are more of a Tempest in a teapot, or if they're obviously failing, be careful about stopping the ibrutinib until you're ready to have the next treatment in line. And here's just a page of references of some of the articles, including the one on the idelalisib management. Thank you.